Okay. As folks come in, welcome. Thanks again for taking your time today on this Friday to join us. It's really helpful to us if you say hello in the chat and tell us where you're from and uh, your role and your affiliation. I'm Laura Line. I am a principal with Bowling Business Strategies. I'm so pleased to be here with my colleague, Sophie LaMarche. And we are about to share the fifth in the 5 webinar series on birth equity, pregnancy, parenting, and drug use. So we've been having these webinars since July. This is the last one in the series. We share the recording and the slides after each. And we always share the list of webinars, the previous webinars, which are available and are, I think they're almost all added to the Delaware Addiction Treatment Resource Center, right? They're all added there now. Okay. So they're always going to live there. And we're gonna, let's see. So the first in the series, we had 2 on prenatal care. And then we had a third webinar on birth in the context of substance use, labor and delivery. This one is our second focused on the postpartum and infant year 1. So today we'll review similar topics and so grateful to have Dr. Kima Taylor and Dr. Mishka Turplin with us today. They're going to do a recap of some of those earlier webinars briefly before we move into this 5th one. And of course, disclaimer, the content, views, etc., expressed in this presentation don't necessarily reflect those of BBS or the Delaware Division of Medicaid and Medical Assistance or Mercer Government Human Services Consulting. And we are really grateful for the Division of Medicaid and Medical Assistance, DMMA, in Delaware for supporting this series. So with that, I am going to turn it over to Dr. Taylor.
Thank you, Laura. And really, again, we want to thank everyone for attending the webinar today on our 5th and final of the series. My name, again, is Dr. Kima Taylor. I'm a pediatrician by training, have been in this space for quite some time with my partner. I gave the longer bio in many of the webinars, so this is a reason to watch those others. But I'm going to now let my partner introduce himself, Dr. Turplin.
Hi, everybody. Mishka Turplin, OBGYN addiction medicine. And I just also wanted to thank, Delaware Medicaid for supporting this topical area and Sophie and Laura for, being just like wonderful collaborators in this content.
Awesome. Thank you. Okay. And I'm really excited by the diversity of folk and areas that are in the webinar chat. So that's neat. It also demonstrates how universal this topic is. So just to give you an idea of the agenda, first, my colleague, Dr. Turplin, is going to go through some of the context. No, I'm going to go through some of the context, and he's going to recap some of the previous webinars. Then we're actually going to have a great video, about a 13-minute video by Rachel Hernandez, who many of you saw in some of the previous webinars, talking about her postpartum experience. Then we're going to go through the 4th trimester postpartum from the parenting perspective, the infant perspective, the dyad perspective, and open it up for discussion. There are going to be some times, I should say, in my presentation that we may ask you to put some things in the chat. So hoping that this can be interactive and kind in its interactivity. Just to recap again, the reason we are having these conversations, because we all know that comprehensive treatment and medication are rare and unavailable for most pregnant people with substance use disorder. And this is what we're trying to combat. And what is our goal? Why are we doing this work, and what do we hope to achieve? Really hoping to see equitable access to and outcomes from culturally and linguistically effective, community-based, non-punitive, person-centered health and social services that really seek to preserve and support families and that support improved wellness for parent, infant, and dyad. It's a mouthful, it's a lot, but it's important and we can actually get there if we work together. So again, just to do some level setting, which I've done in the previous slide, so I'll go a little more quickly. Equity is not the same as diversity, equity, inclusion, though the latter part is key. Having that diversity within your organizations is key, but equitable outcomes are not the same, nor is equitable access. And equity and access does not necessarily lead to equitable outcomes. You can have many people coming into a system, then that because of stigma, other reasons, they're not treated well, and so that does not lead to equitable outcomes. So it's important to look at both. Really important to look at equity and equity lens in all areas: policy, practice, programs development, implementation, and valuation. That doesn't mean, oh my gosh, it's so huge, I'm paralyzed. Start in one area and then spread the work, but get started. This really requires changing the way we were taught and often changing the way we think. It's not, it's not like adding an equity as a pull out add-on or tag along that you just put in any paper you write but don't do anything about. It really requires thinking about the many different policies, practice, and programs that have been embedded within equity and how to deconstruct them so we really get to those equitable outcomes. And for me, the key is really equitable outcomes, and that requires looking at data and having accountability for achieving these equitable outcomes. And so, yes, it is hard, but it is achievable, particularly if we work across sectors and work together. So again, I always put up this quote when I'm having these talks, because we come from a history in this space that really didn't support equitable outcomes and really cemented inequities. And so I'm asking you to kind of let go of some of the things you learned before and come in with a different perspective that seeks a different Northern Star. And this quote is from Transcendent Kingdom by Yag Yasi. And it says, which is a great book, you should read. But anyways, but it says, I mean progress in the sense of the natural way in which learning something new requires getting rid of something old. Like how discovering that the world is round means you can no longer hang on to the idea that you might one day fall off the edge of the earth. And now that you've learned that something you thought was true was never true at all, every idea you hold firm comes into question. And so we're really asking in this work to let go of some of those past punitive, hostile policies that really didn't seek to provide the well-being services that folks need, and work together to create something new that centers that family, that dyad, and leads to equitable, positive outcomes. So now I'm going to turn it over to Mishka. So I will control the slides until the video. How's that, Mishka?
Great. And just to sort of recap, like the structure of this, these were 5 videos or 5 webinars that really wanted to hack the course of pregnancy, from sort of preconception care through prenatal care through the birthing hospitalization, and now we're in the sort of postpartum period. And I want to note that that is, although that's maybe more towards a life course than only focusing on the gestational period, it's still in and of itself incomplete. And I'd like to, even take a further step back and think about how reproductive health life courses, are embedded within, sort of the larger life course. So some of the things we're going to be talking about today related to really care in the postpartum period, relate to care in, in childhood, care, in menopause and postmenopause and etc. So really, as we all, exist in an arc of time, so too should our clinical care and delivery environment reflect that as much as possible. So we started with prenatal care and really with preconception care. We walked through its difference between screening and testing and talked about what professional society recommendations are. We talked in some detail about the treatment, of substance use disorders, with attention to medications for opioid use disorders, but also attention to other substance use disorders, as well as sort of the consequences of in utero substance exposure. We brought some people in to share their personal experiences, to also talk about plans of safe care, and really to think about, everything is sort of integrated and inclusive. So how do we include, the birthing hospitalization in a way in our outpatient prenatal care management? How do we include postpartum care expectations and planning and et cetera that we'll talk about today in our prenatal care and our birthing hospitalization care management? You can go to the next slide. Because then we transitioned, from prenatal care to the birthing hospitalization with attention to labor and delivery, and in particular, sort of the principles of care and the analgesic, needs that people might have that are different from people without, a substance use disorder. We spent a bunch of time kind of drilling down on, what is mandated reporting, what are the parameters of it, and really what are the consequences of what we call an over report, which is a report in excess of what the legal mandate is. The last time we initiated our talk about the postpartum period, and we concentrated more on this sort of immediate, period. And tried to highlight the important role of warm handoffs, connections between health systems, and we'll talk more about this later, and sort of non-health systems, the role of, potential role of like home visiting, early intervention, WIC, those highly critical like structures in the public health ecosystem that aren't as connected as I think we would like to see to clinical care itself. And we also highlighted sort of the principles of chronic disease management, which reflect that life course perspective that I touched on before. And so with this, I think I'm turning it over to you, Laura, to share a video of Rachel, who's been on the webinars before, who was unable to attend today, it's about a 10-minute video or so of her talking, and I ask her a couple of questions. So it's in lieu of live living experience. It's a recorded living experience.
Thank you, Mishka. And I'm going to stop share to get the video up on screen and we can all look at each other. Hopefully the technology gods are smiling on me. And I am super grateful for Rachel taking the time to record this and for Mishka to record it for us. And if you haven't, please do put your affiliation and your name in the chat.
Hey everyone, my name is Rachel Hernandez. Grateful to be here. I was asked to come and speak and talk about my experience with postpartum. And I'm sorry if you see like my cats running around or my daughter come and interrupt. We are recording this. I'm unable to be there in person. But grateful recovering addict, working on 4 years clean, and I'm just glad to be here.
Thank you. Can you tell us a little bit about like when really the year after you gave birth, the postpartum period, what that was like for you and interacting with healthcare professionals?
Yeah, absolutely. So my first year postpartum, I'll start off by just saying it was an extremely stressful year for me with everything. So I had recently gotten arrested and spent my 3rd trimester in jail. And then shortly after I gave birth, I dealt with court and everything. So I immediately was sentenced to like drug court. So I gave birth and immediately started drug court and probation. So it was just extremely stressful right off the bat. But I was also one of the first patients at the hospital I gave birth at to go through a new program with the Subutex while being pregnant. So my first year, leaving the hospital immediately, they made sure I was good to go as far as like a pediatrician. They recommended a pediatrician in my area. So I followed up with an appointment there. I came back to the hospital and met with the OB/GYN for the postpartum appointment. I didn't really deal too much with postpartum personally. I didn't really go through any like sort of depression or anything. I think it's because I was so busy being stressed out about everything else going on in my life at the time. I had to attend all kinds of meetings. I had to do intensive outpatient. And then on top of that, I was a first-time mother, and I was also dealing with trying to get off of the Suboxone because I knew that I did not want to be on Suboxone long. So I went to my family medicine doctor regularly, and he did a very good job at weaning me down perfectly. So the first year it was a lot of doctor's visits with the family medicine doctor, all the pediatricians, and then, or not all the pediatricians, all the pediatrician visits, and then just dealing with the stress of being a new mom in recovery. And yeah, it was just very, very stressful that first year.
It sounds like it. Yeah. And do you remember like what, when you went to the postpartum visit, like did they talk to you about things? What was, how did they talk to you about mental health and other things?
This is Raiden. You say hi. Hi. I'm in a meeting, baby. Specifically, I don't remember the exact questions that they asked or that he asked. I just remember kind of more basic questions like, how is everything? How is it at home? Like where you're living? Like what's the situation like with the dad? Because when I left the hospital, I got pretty close with everybody, and they knew that I was like trying to end that relationship. So like what's the situation going with dad? Stuff like that. And then he asked how I am with the Suboxone and how coming off of that is. Mental health, I mean, I believe it was just like pretty basic questions, like just how am I doing and how is everything in my life. They did ask me about like WIC, that whole program with the I forget what it stands for, but the mother, like help with new moms and stuff like that. But specifically, I don't remember any questions like kind of far out like that. I remember it being pretty basic.
And did you have any concerns about, what the heroin or the Suboxone exposure might be for your, child's development? And did you ask about, was that a content? Was that something you worried about and something that was discussed?
Honestly, I don't think we did really discuss that. To my knowledge, I don't remember discussing that, but it definitely was a worry and a concern. And even to this day, it still kind of is like anything that happens with Raiden, it could be the smallest thing, like, oh, she's not eating much, like, is it because of that? Just everything kind of always falls back on, is it because of that? Which probably isn't the best way to think. I should probably be more positive, but I guess I just can't help it. And, I definitely do have trouble like blaming myself a lot for, what I put her through and myself. But no, I don't believe that he ever discussed anything about possibilities of dealing with that or anything. If it's even something you can know, we didn't really talk about that. But I also didn't ask much either. I was just like, okay, so so far she's fine. Everything looks good. She shows normal signs and has normal tendencies of a newborn. And it kind of just left at that, or was left at that.
Yeah, I think, I asked because it's, as you say, it's like a common, it's concern and something that you like still have and might always sort of carry with you. And
and because it's a common and concern that, you know, like, and maybe it's almost like asking too much of people to bring that up themselves, but it does sound like your providers provided reassurance, you know, although maybe not specifically, you know, in that way by you know, reflecting back to you her normal development and all of that sort of stuff. And I will share that there is, you know, really no significant long-term neurodevelopmental outcomes related to exposures of heroin or of, you know, or medications for addiction treatment. And really, you know, like the strongest predictor of you know, good, strong, normal, like development is a strong stable early childhood development environment is the dyad, is the, you know, the care and structure that your presence and your love provided. So I can imagine that you will maybe continually interrogate little things from that perspective, but I will say that that would not be, you know, scientifically accurate.
Yeah. And I guess it's just like, that's my go-to thing, you know, which like I should probably fix that. That makes me
I mean, or it's like, I think that, you know, we've talked about this in the other webinar too, how like how people like, you know, with you know, the condition of addiction oftentimes like blame themselves more than, you know, than anything else.
Oh my goodness. What? She's watching Spider-Man. I'm sorry.
Oh, no worries.
That's Dr. Mishka.
Hi.
Dr. Mishka.
I do like the beat.
It's okay. All right, I'm working.
And I guess maybe we can like, you know, we can end with is there something that you wish like you could give to health professionals to have them, you know, do their work even better and, you know, than they already are, specifically in that year following birth?
I guess I would just say staying as involved as you possibly can. That's the only thing I can really think. Like, just continue following up and making sure that all concerns are just kind of like, you know, met, and as much info as you can possibly give to relieve stress and worry about everything dealing with being a new, even if you're not a new parent, dealing with, and I don't like saying it because it's not even accurate, but a baby that was born with substance use, you know, anything that you can say to eliminate any worry, that would help extremely. Because like what you just said, it's like a bump on the head. It's like, okay, calm down, you know, like you're fine, you're doing everything that you're supposed to. Just, she's just being a normal 3-year-old. Like, she didn't eat that week. Sure, lots of 3-year-olds do that, you know. It's not, stop beating yourself up, really, which is hard to do, but you know. So I guess just giving as much information as possible to eliminate any doubt about those concerns.
Yeah, and then like also like also providing supports, you know, beyond healthcare or connection and stuff like that that are needed.
Yeah, I love pamphlets. Like, it's a way of saying, like, giving you options without like throwing it in your face, you know. It's like, and here's some info on these places or these connections, just in case you ever need it. Like, there's, you know, it's not like, oh, here, like, you need to do this, this, and this. It's just putting it out there so you have it. And I'm a big paper person. I like holding it in my hand, you know, all this electronic stuff that'll like slip through my fingers, but paper, like looking at it, seeing it, reading it is like a big deal for me. So I love pamphlets.
Yeah,
Like,
resources and sort of like and delivered in a way that's like a menu of options and sources that you can go back to later, not as this is something you need to do now.
right, because nobody likes being told what to do.
Mm-hmm.
But if it's offered as an option, I will definitely hear and listen to those options. So yeah, that's a good one. Yeah, definitely offering resources to you for sure.
Excellent. Well, thank you. Thank you so much. Any last words?
Just thank you so much for having me. I'm super grateful to be here. And anything and any way, I'm always willing to be here for that. I love this work. I absolutely love it. And I'm just extremely grateful for y'all including me. And I hope it helps. I hope I can offer you whatever you need.
Great. Thank you. Some really great points in there. Thank you for that. I am going to find that slide deck.
Yeah, well, just to echo, like, just want to, as you're pulling up the slide deck, to echo, thanks to Rachel for sharing her story, for Reagan, actually really modeling what we're going to be talking about, which is like love and the dyad and development and interconnectedness. And also like the other things, that she, I will request remote control. And the there we go. And really, like, it illustrates, as I said, sort of both the dyad, which we'll talk about briefly, as well as, like her perceptions of, in particular, the postpartum care, which is of concern to me as an obstetrician gynecologist, as being, in her words, twice basic, which might be insufficient. As well as, sort of the importance of communicative strategies that resonate with the people that we're observing, and that not everybody has the same methods or the same uptake of different methods, and hence a multiplicity of choices and options and ways of communicating. So really, I think the core thing that we've been talking about is the dyad. And we've shared this slide before, and this is in many ways, I think, perhaps the best summary definition of the dyad from Dr. Winnicott, who was a pediatrician who retrained as a psychiatrist and wrote this in the mid-60s, that there's no such thing as a baby. If you set out to describe a baby, you will find you are describing a baby and someone. A baby cannot exist alone, but is essentially part of a relationship. And he wrote that, now like more than, why is it not advancing? Oh my God, now it's advancing too much. All right, slow down. Although he wrote that, like 60 years ago, there hasn't been really a huge amount of attention in clinical care or in biomedical research or in public health, really, to what that means and how do we actually provide dyadic care. I share with you two recent-ish publications that come from an HHS work group that has become focused on trying to operationalize what the dyad is and think about how do we actually, can we provide truly dyadic care in pregnancy and in particular, through the postpartum period. And the work really began, as illustrated on the right here, in the context of neonatal abstinence syndrome, and has been slowly expanding. And really the one on the left that approaches a definition of a dyad, I will say, really sort of shifts the focus of opioid-exposed dyad from two individuals, who are two, almost distinct patient populations, to an interrelational, unit that has broad applicability, I would say, beyond just the care of, pregnant and parenting people who use drugs and their infants. The principles of dyadic care really extend beyond or are not exclusive, to that population. So we're talking about the postpartum period. And people have used the term fourth trimester, which I like because it's a term that's inclusive of the, first 3 trimesters. And it's defined in different ways, but I'm going to use it in the most expansive definition, which is really the 4th trimester is the year following birth. And this is like a critical period. This is, a time of, there's a newborn, there's, breastfeeding, there's the importance of attachment. This is a time of normal, oftentimes mood changes, normal sleep disturbances, normal physiologic changes. This is a time where the sort of cultural, norm of the ideal mother collides with the actual reality in our society of caregiving. Regardless, of Medicaid expansion and stuff like that, this is a time of insurance and welfare realignment, oftentimes because the denominator of the family has changed with the introduction of a new child. And the responsibility for the continuation of services oftentimes rests on the person and isn't always automatic from the state. This is a time that's neglected. And care goes from weekly prenatal care visits to maybe a couple of postpartum visits. Within the healthcare system, it shifts from being focused on the pregnant person to being focused on the child. And generally speaking, I think it shifts away from health services and more to those other dimensions of care that we touched on earlier, WIC, early, home visiting, stuff that kind of exists outside of the healthcare system. And in many ways, there's not, who is the sole continuity of provider? For Rachel's story, it was actually the family medicine doc. For other people, who was providing the addiction treatment. For other people, it might actually be the methadone clinic is the sole continuity of care through this transition. A care provider that may or may not be super attuned to the needs of people with substance use disorder. So historically, and when I trained, there was one postpartum visit. And it would be, sometimes there could be 2 if somebody had a cesarean delivery and you need to check the scar, but it'd be around 6 weeks. And attendance at postpartum visits was poor. A minority of people came. In like a comprehensive clinic I ran, 20% of people came. And we saw during the COVID, when care flipped, postpartum visits became virtual, there was a slight uptick, but on the whole, still a minority of people attended the visit. So this was evidence of sort of an attrition of care. And in 2018, ACOG changed how it conceptualized, it redesigned, postpartum care from sort of a one-time episode that's supposed to close this chapter of pregnancy to trying to think about how to provide postpartum, how can the postpartum visit be part of an ongoing process? And this is the figure for their, for this paradigm shift. And it means earlier contact with everyone, not just with those that had a cesarean delivery. For people who had elevated blood pressure and other reasons, regardless, like a blood pressure check. And depending on sort of acuity, you might need more frequent visits than historically were done in the postpartum visit. But care was individualized and really ongoing as needed. And I would say for anyone who's under treatment for substance use disorder, they need ongoing care in the postpartum visit. Now, this document, which we're happy to share if you don't know it, has lots of sort of suggested components, both sort of structurally that are here and clinically that are going to follow, related to the, what does care look like? And this care plan, which has a resonance, not articulated in this document, with family care plans or plans of safe care, just to think about that, relates to what's the care team, what's the frequency of visits that's unique, individualized for this person. thinking about you can see the dyad reflected in here, and that there's parts that are infant, parts that are parent, talking about reproductive health plan, following up on pregnancy complications, including mental health and addressing postpartum problems that we discussed in the last webinar, as well as attention to chronic medical conditions. But the care team is actually greater than that. That's sort of like the clinical care team. This is sort of like when we're thinking about like warm handoffs and what's the network and what's the life course management of this for this individual to be. It's more than the primary care providers. It's good. There'll be times of lactation support, but it's really also inclusive of family and friends, of people's supportive social network, as well as, care coordination, which can be a very meaningful service through Medicaid, as well as linking in better that those other programs, that other parts of the public health ecosystem, like, early Head Start, home visiting, and things like that. And in terms of the actual care component, it's holistic. And it looks at not just like mood and emotional well-being and infant care and feeding, but also addresses sort of sexuality, contraception, birth spacing, talking about sleep and fatigue, common for everybody postpartum. There's a literature looking at sort of sleep disturbances and increasing perhaps the vulnerabilities to return to use and SUD recurrence. So I would say for this population, particular attention to sleep is needed, thinking about physical recovery, chronic disease management, and also sort of health maintenance. And again, I would, vaccinations, cervical cancer screening, and screening and follow-up, for people who are Hep C positive, and perhaps maybe people who might be at risk of syphilis and other STIs. This is another paper that I'm happy to share with you that really tries to use a harm reduction lens to to how to think about supporting engagement for people with addiction in the postpartum period, and really is kind of like grounded in the recognition that care attrition is common for addiction treatment postpartum. There's not as much literature on this as you would hope, but none of it looks super great. This is an older study here on the left looking at people who were enrolled in methadone during pregnancy, and this is sort of the attrition curve through the postpartum period. You can see, by 1 year, maybe less than 40% of people are still enrolled, and as you go further out, adherence decreases. And on the right-hand side, this is looking at all medications for opioid use disorder, so including buprenorphine, and looking at attrition. And it's not as great a curve, but you can see like a decline, but a decline that has that reflects, racial inequities in society. Where compared to white, non-Hispanic people, people with other racial identities have a decrease in adherence to medication that might reflect access, might reflect structural racism, and is certainly an inequity that we need to remain attentive to as we sort of as we implement that ACOG postpartum redesign. So what about split dosing? We talked about this during pregnancy, that because of the metabolic changes and physiologic changes of pregnancy, many people will need to have either a dose increase or more physiologically correct, actually a split dose of either methadone or buprenorphine. And that everybody in pregnancy really becomes a rapid metabolizer of methadone. Hence, split dosing really should be probably the default setting for a methadone administration. And I would argue too for buprenorphine administration in pregnancy. So if somebody had a dose increase or had a split dose in pregnancy, when do you go back to daily dosing? There is actually no literature really that guides us on that, in part because it reflects that previous slide that attrition is super common. So care is really individualized, and if possible, like maintaining people on, split dosing would be the way to go, and monitoring people for symptoms, both of undertreatment, which cravings would emerge before withdrawal, and even of overtreatment if you've had a dose increase, which might actually, one of the first symptoms that might manifest might be constipation before you would have sort of lethargy and stuff like that. So this care is individualized. So kind of in conclusion, the optimal care of chronic conditions really requires continuing care. And we need to sort of continue to reconceptualize postpartum as an ongoing care process that's contingent upon each individual's unique needs. And and care is like, continuation of medication is critical, but care often lapses. And so ensuring continuous health insurance, health providers, and quality of care is key, and all care needs to better focus on the dyad. So with that, thank you. And I'm
Thanks.
turning over to you.
Thanks, Mishka. Awesome. And so now we're going to talk a little bit more about the infant and dyad. And again, as Mishka mentioned, early and through pregnancy, a lot of the attention was pretty much focused on the parent and really focused on the pregnant person. And now, ideally, the idea is that it's really a parent, a child, and dyad existing in a family as they define it that are in need of care. And so really rethinking how we provide this. Now the parent needs care and support, as is the infant, as does the dyad. It can be really overwhelming for an already exhausted person. And so it's really important, and Rachel alluded to this, to really earn trust and be trustworthy and work in partnership with the parent. So get to know them, make sure that you're a place, as she said, that they can come and ask questions to, because again, it's a lot. And be humble. And by being humble, that means, in one, practicing culturally humble care, but also being humble to know that what you don't know and really being open to listening. Because this family is entering in really a set of healthcare systems that are often siloed. Each one of them is often incredibly cumbersome on their own, much less put together. And for one patient, much less a parent, child, and their dyad, it's often hard to figure out how to move forward, and particularly how to move forward in a space that often hasn't provided high quality service, has often stigmatized, has often punished you. And so really to understand how we're doing, and I alluded to this before, it's going to be important to keep data to understand whether you're continually improving, whether you're getting to this positive equitable access measures and outcome measures from your culturally and linguistically effective, non-punitive health and social supports. And this means data, like how many people got their shots, yada, yada, quantitative data, but also actually talking to your clients and saying, how are things going? Don't guess how you're doing, like ask. And assess, and if you need to make changes, then make changes as needed. And that goes along with humility and not expecting that you'll get everything right for every patient, because as Mishka said, this is really individualized care, and understanding what needs to be changed is going to depend on each person. So just to do a brief recap, and we talked about this is a kind of shout out to go back to video 4, but we talked about newborn assessments, and we talked about eat, sleep, and console. You did that. We talked about providing interventions as needed, the baseline, continuing non-pharmacological interventions that were mentioned before, but also pharmacology as needed. We talked about weaning as able in the nursery or after going home, and talked about breastfeeding if desired. If parents are interested, talked about breastfeeding, that unless there are other contraindications, but recognizing that medications for opioid use disorder are not contraindications, and then providing support as needed. For instance, if someone needs a lactation consultant, being able to provide that in a non-punitive, non-judgmental space. Further recap. We talked about discharge. And as Mishka alluded to, last time we really talked about really immediate time post-birth. And so discharge usually at least 48 hours after birth, if not more. The infant has had the necessary blood tests, hearing tests, heart screens, vaccines, vitamin K, all of that as appropriate. And you've sent them home with anticipatory guidance that they should follow up 2 days post-discharge and with their pediatric provider, that ideally, as we talked about before, they met prior to even having the infant. They met and recognized and established a relationship with. So now they're having to meet with them again within 2 days after discharge, gave them anticipatory guidance around car seat, safe sleep at home, and those other concerns. And then lastly, in terms of the discharge, really more focused on the substance use disorder. Again, a discharge checklist for folks with opioid use disorder that we talked about, the AAP checklist, which mentions many of the things Mishka talked about: early intervention, nurse visiting, hepatitis C testing, syphilis, all of that, that we're going to discuss more. And so that's kind of a recap of what we talked about last time. And that was really immediate post-birth. And now we're going to think a little for the year following. So we're going to do something called a chatterfall. And what that means is I'm going to ask you a question and you're not going to put anything to chat. I'm going to give you a minute to think about it. And then when I say go, you're going to put some of your ideas in the chat, and they can be on, anything that, setting my timer, anything that comes to mind. And so the question is, now the parent and infant are going home. What are some of the challenges that they may face? And how can you, as a health service or social service provider, help to eradicate some of the challenges and support some of their strengths and opportunities? So I'm going to set my timer for a minute. Again, do not put anything in the chat now. And then when I say go, put it in the chat. And that's really just to offer an opportunity to think. Okay. Now start putting some of your ideas in the chat. And ideally, two things are going to happen. Ideally, we're going to touch on some of these as I go through the rest of the talk. But also, if we don't, we're going to go back to them towards the end. But please put any ideas that you have. How can you help eradicate some of the challenges and really support some of their strengths and opportunities? Awesome. TLC Mama Hotline, give them food, transport. Lack of support, stable housing, lack of baby supplies. Yes, yes. These are awesome. And I also like to do these chatterfalls because often when people look at the responses, it makes you think, yeah, that's true. And I know someone that we can link up to. We are, and I will say, much like the other conversations we have, there will be resources at the back end. This is great. So you can see how many of I addressed, and then you can hold me accountable at the end we'll go through them. But really thinking of the first few days, this is something we talked about before, but really support that early bonding as much as possible. Mishka alluded to the fact that you're often told, having an infant is this magical time and everything works out perfectly and you immediately bond and every person can perfectly breastfeed. And so if that does not happen, often it leads to parents having deep guilt and, I could be projecting from my experience, but it makes it really hard. And so it's really important to support early bonding as much as possible, particularly, again, in situations where parents have been told what they're not and they're being surveilled. Really support that early bonding and help them recognize that it takes time. Help them to embrace the special moments of holding the baby close, making eye contact, feeding close, console. And that really also means helping people to prioritize. Often if people are coming in, you're like, I have to have a crystal clean house. Well, one, unlikely when you have an infant, but two, actually help them prioritize holding that baby, loving that baby. Helps them to be able to ask for help and know where to ask for help. Again, in a situation where people have been punished, sent to jail, criminalized, it's often hard to ask for help because you're not sure of the consequences. So really sit down and, it's interesting as Rachel was saying, her providers knew her so well, and she had so much trust in this partnered relationship that they're like, well, how is it going with the partner? Asking folks, who is it in your family as you define it, or outside of your family that you can ask for help, and ask them for the help for cleaning. A lot of us are bad at that, but tell them it's okay. Let others bond with the infant, and that allows you to get a little bit of sleep, allows you to take that shower, etc. Help them play, sing, and read to the infant, offering free books through the myriad programs that exist, like Reach Out and Read. But have them interact. This is one thing that I really love to do when I was seeing patients. Remind them that no parent is perfect, that you actually will make mistakes, and that you can, instead of like just perseverating in that mistake, allow yourself some grace and kindness and do it differently the next time. We have all these books out there that's saying who is the perfect parent, and allowing for that grace and kindness. And that really bumps up with this child welfare conversation, because often there's extremely increased surveillance of parents who pregnant parents can be loose drugs, and they often aren't allowed that grace that all of us really need, because it is hard to parent. And finally, assess them for depression, exhaustion, and offer the support as possible. And this is the pediatricians I'm talking about. Pediatricians really having the capacity to assess for depression, exhaustion in the parent. And in some places, they can bill for that in the child's Medicaid. Thinking of the dyad and care coordination, again, it's all a lot. It is a lot. And so looking at whether your team has a case manager or care coordinator that can help, or their trusted partners that might help. In Delaware, the MCOs have care coordinators that can sometimes help. But recognizing the system is asking a lot of a parent, and knowing the system is often siloed and hard, providing those supports that are needed. And care coordination really can help. Making sure it's important to notice that this care coordination and services have to be trusted, again, offer those culturally and linguistically effective services, non-punitive, non-judgmental, and be knowledgeable about other services they're referring you to that have that same piece. And care coordination, effective care coordination, really partners with the parent and infant dyad to understand what supports are needed. And it's important to ask what supports would be helpful, and then ask which ones the parents actually need. And I distinguish those, because asking from the full panoply of what supports will be helpful, and then understanding what already exists within their sphere, and then which ones they need support for. And it's offering that choice, not saying you have to do X, Y, Z. As Rachel said, no one likes to be told what to do. Ask what's needed. And that often requires doing a screen for societal determinants of health, and making sure it's a culturally linguistically effective screening tool. One example is Prepare, an example, not an endorsement, but one of them is Prepare, used often in FQHCs. It's offered in 25 languages, which really gets you to that linguistically effective space. But doing some sort of screen and then asking folks what they need, and helping to develop relationships outside of your health services space with providers, other providers, if they need specialty care, if they even need specialty care, for instance, community-based organizations, and others that can provide this culturally and linguistically effective supports. So if the parent says, look, I really need a crib for the safe sleep, for my infant to have safe sleeping environment, link up with folks that offer free pack and plays, who offers lactation consulting, childcare, diapers, formulas, many of the things that you guys mentioned. And as you find those places that really provide that non-judgmental, non-punitive dyadic care, create referral and feedback loops so that you can refer patients to them. But often, if they have someone who comes in who hasn't been so trusting of the healthcare service, they can send patients back to you. Working with the family support systems, and Mishka alluded to that too, and the team of care, bringing the family as they define their support system in to hear some of the anticipatory guidance and allow them to ask questions. We do this a lot, particularly around safe sleep. Often extended families like, no, you got to put the baby on their tummy because that's the way they sleep better. And so they bring them in to understand why pediatricians say that babies should sleep alone on their back in a crib without exposure to smoking, and being able to have that back and forth. But then also, again, the parent is exhausted, and so having lots of people hear and understand that anticipatory guidance really provides the support if they don't remember everything, right? So having, again, partner care coordination across physical health, behavioral health, and social supports. And thinking about it from the parent's real life situation, there are a million appointments to go to. And so sometimes does that mean we can make appointments for both in the same day in the same clinic? That may be easier in some settings like an FQHC than others where you're going to individual spaces, but really trying to work it in terms of the real life experiences of the parent. If they have 5 appointments and you know they also need to sleep and they also need to feed, how can you create a schedule that's going to make that doable and that's going to be kind to both parent infant dyad and their needs? And that becomes particularly important, and you need to understand if they're involved with child welfare, what is that child welfare set of requirements so you can fit those in. Let me see, next slide. Wait, 57. Okay, go on. I do want to talk about some of the other supports that are needed, and we're going to talk a little more about home visiting. So I'm going to go through this quickly, but as people mentioned, offering home visiting as supports. Childcare, there's this great, I recommend reading this conversation about childcare, but we often talk about parents and their infant as if they don't have other children. Often people do have other children and they need childcare, especially as they're going through those 600 different appointments. So really thinking about childcare either at home, daycare, early Head Start is a great opportunity. And there's some resources at the end of the slide that talks about some of Delaware's resources in that space. Think of other supports such as housing. Are you talking to the client? Do you know if they're housed? Are they unstably housed? Now that they have an infant, has that jeopardized their housing? What are there barriers to housing because of substance use history? Similar to employment, substance use has infiltrated every part of our systems in a punitive way. There's often many barriers to housing, employment, because a person has a history of a substance use disorder, or because of the way we treat substance use has a history of criminal legal involvement. So understanding that, understand what it means, and really working with community-based organizations and others that recognize this reality and have relationships to make it real. This also plays into, however, particularly employment, when people can get the appointments, what those appointments look like for some of the services that we're recommending. So again, most systems have left people, most systems are ill-equipped to address the services that people need. Much less folks who use drugs, and much less pregnant and parenting people who use drugs. So recognizing that and building those relationships with institutions and systems that are starting to learn that, and maybe educating those that aren't. Our history has institutionalized inequities in all that we do and institutionalized punitive responses in all these spaces. It supported the financing of systems that often lack education about and uptake of evidence-informed, culturally and linguistically effective services. And it's created righteous community and family mistrust because of past harms and disproportionate punitive responses. Ignoring that and being like, well, we now offer services isn't really going to build the trust you need. It really is going to be deconstructing what you offer and then taking the time to earn the trust with the folks and families that you're seeing. No one size fits all, and understanding that is going to be incredibly important. You will have access to the slides when we're done, because I just want to make sure that we get to some of the Q&A periods. Home visiting is something we've talked about often, and I'm very much a supporter of home visiting if it's high quality. But if it's high quality, it has been shown to really prevent child maltreatment, support child maternal health, support child development, school readiness, improve family economic self-sufficiency, and support positive parenting practices. But it really needs to be high quality. And again, because substance use stigma and hostility has infiltrated many of our systems, often home visiting programs aren't necessarily ready to take care of the clients. And so it's not pregnant parenting people use drugs. You can't just be like, use a home visiting service, because studies have shown often home visitors feel ill-equipped to address the complex needs of families affected by substance use. That these studies indicate a need often for specialized training to address issues related to alcohol and other drug use. And some of that specialized training doesn't mean you need a PhD, but it means that you need to understand that it's a chronic health concern and that you don't immediately refer someone to child welfare if they're using methadone. It really means understanding what that chronic concern looks like and the evidence-informed responses to it. Many programs employ paraprofessionals who may need to refer to folks with advanced training. Some of these participants, home visitors serving these participants, have noted that they have high levels of burnout. And there's a need, as we're talking about all this and their interaction with parents, need to really support home visitors so they can provide these equitable outcomes for pregnant and parenting people who use drugs. And so I'm going to give 2 examples. And again, I want to say these aren't endorsements per se. You need to look at what's in your neighborhood, but making sure they really offer and offer the evidence-informed services and understand the needs and the past histories of pregnant and parenting people who use drugs. So 2 of these, the first one is Mothering from Inside Out, which really looks at the intersection of addiction, adversity, and attachment with evidence-based parenting intervention. And it really focuses on the dyad. It's a brief, supportive individual parenting psychotherapy project that's designed for parents of children under 5. And it ideally was put in place as an adjunct to mother substance use services. And so that really, requires not having that drop off and having parents continue with their substance use services. But it's demonstrated some really improved outcomes for the dyad, and just indicating that they can be also delivered effectively with community-based clinicians. Another one is the Team for Infants Exposed to Substance Abuse. It's intensive home-based partnership with pregnant and postpartum women and their families affected by prenatal alcohol and other substance use. It's again shown positive outcomes in reducing maternal substance use, increased positive parenting, child and maternal health, family income, and family housing. And shown effectiveness in goal attainment. And that goal attainment is important because it's where they come together and partner and say, well, what are your goals, right? And using some of that motivational interviewing to address what that parent and family's goals are, and should increase effectiveness in goal attainment. And I just kind of, for the TIES program, one thing that I like are there really 5 guiding principles that women change in the context of relationships that recognize all their roles. And so I often say, women aren't just vessels for their infants. Like, we are complex individuals and have many different roles, and recognizing that relationships and that these roles change requires that understanding to create a therapeutic relationship. Families at risk experience compromised safety and security. So child safety is important, but often that safety is embedded because let's say the parent is unstably housed, does not have access to food. It's not something just about the infant, it's like the family itself. And how do you address that? They have complex histories that include trauma and disadvantage, and much of that is structurally imposed and systematically imposed. History and experience have led often to a sense of powerlessness, that people have done so much to you with this punitive response. Often you're like, okay, I don't feel the agency and power to make changes. And so it's important in that relationship to restore that sense of control, restore that sense of recognition that there are strengths and amazing things parents can do, that they are doing to support their infant, and readiness to change is expressed in a variety of ways. And that requires staff consistency and persistence. And as Rachel said, being there, like making sure they know that you are there for questions and relationships. So this piece, I'm looking at time, this piece is really now going to get into the clinical. And this pediatrician-based piece, recognizing that this clinical piece is going to that pediatric provider, whether it be MD, DO, nurse practitioner. It's talking about some of these early intervention structures that we're talking about. If developmental concerns are recognized, whether or not it is because of substance exposure, but if developmental issues are recognized, that early intervention relationship with specialists, perhaps the child has cleft lip or heart concern that is not related to substance use exposure, recognizing the support and understanding of the specialist role. Parental visits, recognizing the parental need for visits, including their linkage to harm reduction services. Often we only talk about the treatment aspects, but their need to link to harm reduction services, and naloxone is necessary, but naloxone in and of itself is not the only harm reduction technique. And we talked a little bit about this, recognizing their reality, the number of appointments, where they are, whether the people you're referring them to are offering that non-judgmental, non-punitive care. But we get to the first pediatric visit, and we talked a little bit about this. In general, regardless of who that infant is, they're going to go through their history and physical. If it's a pregnant and parenting person who used drugs, often this history and physical is going to include asking about substance use, whether they had neonatal opioid withdrawal symptoms, whether they needed medication for this NOWS, what other prescribed medicine exposures they may have had. They're going to ask about birth history. Is this your first birth? What type of birth was it? C-section, natural, maternal history, including HIV, Hep B, GBS, syphilis should be included in there. Newborn screens, as I mentioned before. And really all of this is in addition to all of the other questions we ask. I really always stress this isn't an add-on. This is a piece of what should be included naturally, and that we do. It's asking about social and family histories. We talked about asking about societal determinants of health. Then there's going to be a review of systems, a physical assessment, and the anticipatory guidance period. That's inclusive of NOWS or other anticipatory guidance. And the piece that I think is really important here is a couple things. Is for the anticipatory guidance and understanding, and throughout all this, if someone is involved with child welfare, really asking about that plan of self-care, asking what child welfare is doing. If we sent someone to a cardiologist, when they came back, we'd be like, well, what did the cardiologist say? Even though in theory, we're going to get a note from that cardiologist. What did they say? Did they put you on any medications? Blah, blah, blah. Do the same for child welfare. Not only will you learn a lot and be able to improve outcomes for that individual patient, you'll learn a lot about what happens within that child welfare system that could be important for your future encounters. And then plan for follow-up with providers, case managers, and others. And I put in here for anticipatory guidance, giving some understanding of when to call provider, but making that anticipatory guidance open, saying like, if you are concerned, please call. Like, don't often parents will wait at home and say, well, I don't want to. As Rachel was saying, I feel bad because nope. You should make it an environment where folks feel free to call. And maybe they'll need to come in, but maybe they just need reassurance that you can provide. Creating safe care. There's this great, this great toolkit that was done by Camden Coalition. And it really talks about some of the tenets of creating safe care and supporting pregnant parenting people who use drugs. And that's relationship building, talks about screening, talks about treatment planning, providers as partners. It's just a great tool to take a look at. So now just talking about looking forward and thinking of some of those pediatric visits, they're gonna have a bunch, as Rachel mentioned. We all know tons of visits that first year. So there'll be sick visits, there'll be regular well child checks, really again, having that ability to call. And some of that might be the on-call provider, some of it may be phone calls during the day, talking to the nurse or medical assistant, might be through email or portals, but really having that capacity to communicate. During the history and physical, as I mentioned asking about that child welfare piece. And then this developmental surveillance and screening part. A lot of the developmental surveillance and screening, as we all know, is asking the parent how that child is doing. And it is really important in this space to recognize that, Mishka said that there's very little evidence that heroin, et cetera, causes developmental concerns, but there are other developmental concerns. And we often focus so much on substance use that we miss other pieces. So if an infant has autism, the marijuana didn't cause the autism, but you still need to evaluate and address the autism for that infant. And so it's really important, as Rachel said, when she was going through, like every time she thinks of something, she thinks, oh, it's because of substance exposures. A lot of providers do that too. And we have to stop that. We have to recognize that sometimes when a kid is sick, it's really sepsis from something else. It really is, developmental concern that has nothing to do with substance exposure, but needs that early intervention. So listening, making it a safe space for the parent to talk about any developmental concerns they have, kids not speaking, whatever, and making them know that this is a partnered place, that we are going to provide services for that. And then again, reviewing the plan of safe care that may have been done in the hospital. And when I talk of plan of safe cares, I really think of these as robust. Every infant should have a plan of safe care. This is one that is inclusive of that substance exposure and what's going to happen, but really reviewing that and understanding if there's a way that you can support all that the parent has to do in there and make it less burdensome. And then, of course, they get vaccines. All of this is in partnership, again. Anticipatory guidance in general, and then based on the infant parent reality, making sure folks know that some of those NAS-NOW systems can last for a week or two post-discharge. And as I mentioned, NAS-NOW should not be portrayed as a death knell. It is a recognized, treatable concern, and it's something that folks can talk about. They can alleviate some of the stress mentioned here, as Mishka said, no significant difference in the neurodevelopmental and growth outcomes among opioid-exposed infants, giving them a sense of security, but saying, look, it's possible that there's other things going on, and we're just going to make sure, if that's the case, that we're going to provide supports. Not everything is NAS or NOWS. And so this last piece, really for the clinical part, is, are you on track? We say do all the stuff. We say do all the stuff. And the thing that always stresses me out, we don't see if it's working. So think about how you can assess for equitable access and outcomes. Equity coming in the door, so it's all comers, but also equitable outcomes, and recognizing many of these outcomes are impacted by systemic structures, punitive laws, punitive policies, and how to think about those. Start thinking about within your clinic how to collect data with the appropriate privacy concerns, but also making sure you don't use data to re-stereotype or to harm people, because we know that often data collected on people with substance use concerns has had that effect. And then making sure that as you're collecting the data, and I would recommend both quantitative but qualitative, as I said, talking to your clients, that you use it. It's not supposed to be then something that you punish yourself and self-flagellate for ages. It's like, how can we use this to make our clinic better? How can we use this to make our services, relationships, referrals better? So making sure you know where you can get the data, who can help you analyze the data. I recommend, again, that qualitative piece, and having folks who've been impacted help you analyze it. What really are some of the barriers? How can we make some of the changes? And recognizing who can help you act on the information. Again, I want to remind us of our goal. And then there's some discussion questions and challenges I put at the end that are focused really on us looking towards that new vision, trying to get over that laser-like focus on opioids, that punitive systems and approaches are embedded in everything. And so we have to re-envision how we're going to create those welcoming approaches, those cultural linguistically effective approaches. These punitive law enforcement responses have real collateral consequences that relate to housing and employment and other things we know people need to help sustain themselves, their family, their dyad, and their recovery. Think of funding differently. It's not just reimbursement, but sometimes upfront funding is needed to really change infrastructure and business as usual. Time. Like people always say, well, I'm a PhD provider. That was my background. And so they'd be like, well, just add on extra patients. You actually need time to develop these trusting relationships. You need space. You need quiet periods so you can build that trust. And the incentives need to align with that time. Often people talk about, well, just increase the Medicaid reimbursement. My issue with that is that a lot of providers, many of them are salaried. So they're not seeing that reimbursement increase. And so what does it take to think through making sure that that is allocated in terms of increased time, team-based care, resources, really think through some of these knee-jerk things we do. More research is done. The punitive frame slowed much research into honest effects, and that slowed research on new treatment, harm reduction, recovery measures, and even as Mishka was talking about what to do now that the baby is born and you've been split dosing. Understanding challenges to new vision is data. We don't have the data, but that also means random data sharing, not the answer. A lot of times people are like, well, what we should do is then share all the data with the criminal legal system. Slow. Like, think of privacy considerations, think of past history and some of the punishment, and what does that look like, and how can you increase barriers so that as you're sharing data, it's not used to reharm or re-stereotype. Recognizing stigma, admitting to stigma so you can eradicate the stigma, and so understand that it's embedded in all areas, and really holding people accountable, providing equitable services and outcomes, and not allowing them to continue their stigma. Racism and other isms are embedded in all of the systems, and US really does like to punish. Often punishment and hostility wins more votes than compassion. So making sure that compassion is embedded and assessing whether it's effective by, again, looking whether you're achieving those equitable outcomes. We need a workforce. It needs to be larger and it needs to be more diverse. And we talk about a peer workforce. Yes, a large, diverse peer workforce is needed where you're offering peers benefits and a living salary, but also career ladder. But we need a diverse workforce in every single aspect of every single thing I'm talking about, and it needs to be expanded. We have enough primary care providers, social workers, anyone. So really thinking about that. So I'm going to close with, again, I mean progress in the sense of the natural way in which learning something new requires getting rid of something old. like how discovering that the world is round means that you can no longer hang on to the idea that you may one day fall off the edge of the earth. And now that you've learned that something you thought was true was never true at all, every idea that you hold firm comes into question. And so really, I want us to build that new world and question what we learned before so that we can really achieve those equitable outcomes for folks. And so I'm going to pass it to Mishka for the discussion.
Thank you, Kima. I'm going to turn it over to everyone else. We have, I think 15 minutes left, and we can, if people have questions, please put them in the chat, and we will answer them. And as you're doing that, is there, and Laura and Sophie also, like, if there's like questions or things you want to bring up, we can do that.
I'm just scaring the chat, and someone, I'm sorry, I can't read your name. It's abbreviated, but someone said, gosh, and we didn't even mention baby blues and postpartum depression. Amen. We did not, and that is huge. And huge in the sense of two things. One, we often don't effectively screen for it, though, as I said, in some places, Medicaid, the pediatrician's Medicaid can cover that screening for the parent. But also, we don't often have this culturally linguistically effective services to support it. And then there's this overlap in the substance use and mental health, where we talk a lot about overdoses, and we always say that, oh, these overdoses are accidental, someone didn't know they have fentanyl, yada yada. But we don't talk about those that are actually suicidal because of the depression. And so I think that's another space where a lot of research needs to be done and talked about. That is right. That is why really we need this linkages to mental health services, physical health services, substance use services, social services, and it really needs to be done in a seamless way amongst systems that are incredibly siloed. So it requires us rethinking the way we provide care. And I know in Delaware, as part of the conversations, many people are thinking about how do you provide that integrated siloed care, and how do you pay for it? How do you structure it? How do you pay for it? How do you think about that? And I know some of those conversations are going on.
Hopefully it's not too loud where I am. I'm always struck in the postpartum period how there's not really a system of care for the dyad, and how women or moms are so responsible for so many different aspects. And I'm just curious if you have any thoughts about, you talked about home visiting, which is great, but like peers and peer recovery specialists and some of those roles that might be supportive during that period.
Michelle and I are looking to see who's gonna, I'll go first and then you can go. Absolutely. I think peer support can be an incredible help. A peer is defined by the person who is looking for the peer, can be an incredible help. And part of that support network that helps listen to and remind folks of some of the anticipatory guidance that can be, sometimes even without postpartum depression, you are exhausted and you just need a shoulder to cry in. Someone can say, like, that's okay, and offer that grace. I think having that additional role and having it covered is important. It could be peers. Some spaces use doulas. Some spaces use, in the group parenting space, it's your other pregnant and parenting people who use drugs that are your peers that are also getting the clinical services that they need for their infant or whomever. But I think that is an important point, and I'm glad you brought it up. Again, I always had this caveat with peers, making sure that they are reimbursed appropriately and have benefits and a living wage and a career ladder, but absolutely.
Yeah, that's a great question. And I think it also reflects one of the, to me, more almost like radical aspects of the ACOG postpartum care redesign is the attention to like friends and family. And sort of like the recognition, as you've been speaking to, Kima, of the importance of connections and community and resource and you know, human capital resources, and that can be administered, that are available and administered to many people through their, you know, social networks, but we can also support through professional and even like sort of quasi-professional you know, health kinds of networks. And and in particular for people who use drugs or have a substance use disorder, it's almost become a truism now that the opposite of addiction is connection. And so that's connection through friends and families when people have those. That can be connection through health professionals. That can be connection through peers, doulas, and other sort of like human social service workers. And I think there's, you know, clear gaps that become visible like in the postpartum period. We think in pediatrics, like, you know, we think about like for kids with chronic disease, like it's the transitions in care that are where outcomes worsen. We think about transitions as being times of vulnerabilities, like when people like re-enter, like, you know, from the criminal legal system. That's a time of increased vulnerabilities. And the postpartum period has a lot of parallels, even on like public health data, to that period of criminal legal sort of re-entry. And it's almost reflected in the old and like highly out of date term that we used to use. Instead of like the estimated date of delivery, people would talk about the estimated date of confinement. And so there's actually, you know, like a parallelism in the language that we used to describe like the birthing hospitalization with the language we use to describe, you know, imprisonment. And the subsequent period is and remains actually sort of similar in terms of vulnerabilities. And so some of that is about connections between health systems and these other actors in the space. Some of this, I think, is, and we've talked about this in other spaces, the roles that Medicaid can play, in particular in care coordination and ensuring, you know, continuation of health insurance. And some of it is, you know, for people who have like, you know, social networks can be that are supportive, you know, can be provided from that. So I think the big picture is that there's lots and lots of different options, which is a good thing. Their lack of connection is not as good a thing, but the fact that there's could be, you know, you can imagine a universe in which there's like this series of, you know, almost like a menu of options of different resources that are available that, you know, that then the person can choose, which supports empowerment, which is a critical component of of recovery and of more. And sort of like how Rachel was talking about how she likes to get like hand printed resources that are, you know, she might not be looking at it right then, but later on, you know, it's something, you know, to refer to. So thinking of that sort of communicative strategy that really goes beyond just reflecting back on what she described as just being care that was, in her word, like basic. We can do more than that.
I wanted to address something Charlene said. Not having a medical professional at home with mommy and baby can be frightening in the first week or so. And one, having a medical professional at home, as myself, still frightening that first week or so. And I think that's really important because it's your brain, it doesn't function the way no one's brain functions the way you'd like it to. And so it's really important to offer that grace. But that's also why it's really important to recognize if you have surveillance systems or someone always, look, we make mistakes. Like you can't be judged on that one mistake because it's frightening, it's hard, you don't have all the information, you're looking for help. It really has to be a space where you can seek connection, where you can seek help, where you can be allowed to learn. And because that is incredibly true. And I often say, like, when a pediatrician before I had kids versus after, like, I was probably a pain in the butt before, right? You're lecturing people, you're telling them what you should do, you're so smart. And then you're like, oh my God, this is so hard. And so really being able to understand that allows you to work from a space of compassion and allows you to think of some of the kind of telling and punishment and surveillance pieces in a different way and hopefully remove them.
If folks want to put questions in the chat or they can unmute, we just have a couple more minutes. One chance for one more question. And Kima, if you want to give me the screen back. Great, thank you.
All right.
No, that's great. Thank you. And thank you, everyone. I know there's some attendees that have stuck with us through 5 sessions, 5 webinars. So super appreciating your commitment. And even if you've made 2 or 3 or just today's, we're really glad that you could join. This is such an important conversation. And so thank you for joining. And super big thanks to Rachel Hernandez, to Kima Taylor, to Mishka Turplin, and to my colleague, Sophie. So thank you guys. And let's see. Here's some resources attached to the slides. And as I said, the slide deck and the recording will be sent out after the fact. Here's some of those Delaware resources. And the list of the other webinars and their recordings will also be shared. So with that, everybody have a good weekend. And thank you.
Thank you. Have a good one.